Good evening, everyone. How are you all? Now, still I can see that few of your name is not here. So as we have been saying multiple times during the classes, that any of you join our sessions, you need to make sure that you write your name, because without your name, we don't know who you are. Okay, so we will not allow anyone to be in the Zoom sessions without your name in here. So if you could please change your name over here. I can see a few of your name coming as iPad and one of your name coming as Android. Okay. One of your name coming as Windows 10. So I don't know who you are, but it's very important for us to know that who is joining our sessions. Okay. So if you can please write your name and rejoin this session, that will be okay. And if you don't do it, then we'll have to remove you. And if we remove you from this class, you won't be able to rejoin. So that's why I keep on saying that, can you please change your name so that we don't remove you? I'm just sending personal message to you guys whose name is coming up like this. Check the chat box in case you don't know you're using this name. Okay. We'll give you 15 to 30 minutes to change your name, and if after 30 minutes still your name is showing like that, we will remove you from this class. Thank you. Okay, so let's just start with our topic today. So this is going to be psychiatry class, which is something that you are scared of, I know, but it's important to understand that psychiatry is a vital subject to pass your AMC MCQ exam. Many of you might not get a lot of questions from psychiatry. Many of you can get a lot of questions, and the questions can be quite difficult if you don't have the basic knowledge. Okay, so make sure you understand the psychiatry quite like, I would say, like in a depth, so that whatever question it comes in exam, you know what they're talking about. So we had our initial class on psychiatry in our trial class, and that was your first class on psychiatry. We are not going to do that same class again. If any of you have missed that class, that's the core of psychiatry. So you'll have to go through that class video from the portal. Okay, so it is available in the portal. Make sure you go through that, because that contain most of the important topics such as depression, schizophrenia. Okay, so those are important, like super important than anything that we will discuss. For psychiatry, it's important to go through some of the research. So we have uploaded UWorld USMLE in the Facebook group. So go to the featured section of the Facebook group and you should be able to find it out. Okay, or you can just search it. So UWorld USMLE, the psychiatry portion of it is very good. It's well written, and it will give you a good basic on psychiatry, and that's what you require, because sometimes questions in the exam from psychiatry are very long question, and if you don't know the like what are the important things to diagnose a condition, then it will be very hard. So I would suggest that the topics that we are discussing in the classes, make sure you go through them from the UWorld USMLE psychiatry. Okay, apart from that, we take mainly the classes that we are doing from psychiatry. We normally take help from JAM and Kaplan Institute to CK. There are few topics that you can go through from MedBullet or RANCP, but these are not very important. So in our psychiatry class 1, we did finish about depression, grief, complicated grief. We discussed about how to differentiate depression and grief. We talked about schizophrenia in detail, schizoaffective disorder. We talked about schizophreniform disorder. So lots of schizophrenia related topic we discussed, and lots of pharmacological questions also we covered on that class, like the side effects of different antidepressants and antipsychotic, because that comes in exam too. So today we are going to start with another topic, which is anxiety disorder. So we'll cover mainly from JM, and some of them we will also do from Kaplan Step to CK. So first of all, anxiety disorder includes a lot of subtypes. One of them is somatic symptom disorder. This somatic symptom disorder, previously in DSM-4, so nowadays the main guideline that gives the diagnosis of this psychiatric condition called DSM. The DSM-4 was our previous guideline, now it is DSM-5. So in DSM-4 guideline, it was called somatization disorder. It was also called as hysteria. Okay, so it has a lot of name, but now we say somatic symptom disorder. So what is this SSD? It is a tendency to experience and communicate mental state and distress as some physical symptom, which means that, let's say someone is under a lot of stress, and sometimes it is difficult for a person to say that I am stressed, but your body or the person's body will have a balance, that they will not say that they are under a lot of stress, but they will produce some physical symptom. So it is called mind and body axis, where a person who is under a lot of stress, they can produce certain physical symptom or some altered body function. Like, let's say that if you are, let's say your final exam is tomorrow, and you have been quite stressed about it, and you'll see that before the exam, lots of people has bad headache. On the day of the exam, they have diarrhea. So these are actually the bodily symptoms that they produce to vent out their emotion or stress. Okay? So somatic symptom disorder means that patient actually doesn't have any organic pathology, but they're having some physical symptom as a mean to alleviate their stress or distress. Making sense? So this kind of patients are usually female patient, young female patient. So patients who suffer from this somatic symptom disorder, they can have symptoms everywhere in the body, but most of them has multiple pain. Everywhere there is pain. So somatic symptom disorder patient, they will have multiple disorder in different part of the body. Like GIT, they can have nausea, vomiting, abdominal pain. Genital, they can have dysmenorrhea, dyspareunia, genital pain. Cardiovascular, chest pain, shortness of breath. Pseudo-neurological, they can have amnesia, loss of voice, dizziness, difficulty walking, swallowing. They can have pain every joint, like neck pain, back pain, knee pain, everywhere, headache, fatigue. None of these symptoms has an adequate physical explanation. Okay, so that means you will not be able to find out any exact cause of these symptoms, because patient is complaining pain everywhere. Patient is complaining symptoms everywhere. So that's the time you would think of that maybe patient is under a bit of stress, and that's causing these symptoms. So you can see from here, somatic symptom disorders. So have a read in here. Mrs. Smith has been married for 10 years. And during all of these years, she remembers being sick all the time. According to her husband, she constantly takes medication for her ailment. She has visited numerous physicians. None have been able to correctly diagnose her condition. Today, she presents in your office complaining shortness of breath, chest pain, abdominal pain, back pain, double vision, difficulty walking, weakness in her leg, headache, constipation, bloating. So you can see that multiple organ is involved, but when you do the physical examination, there is nothing. Like patient complaining abdominal pain, but if you check for tenderness, there is no tenderness. Okay, so that's somatic symptom disorder. So it is a disorder where one or more somatic symptoms that are distressing, resulting in problem in functioning. That means when multiple body or when multiple system is involved in a patient who is under a lot of stress, that's what we call as somatic symptom disorder. And most of these patients will have a long, complicated medical histories. They will go to numerous physicians and they will have like multiple number of investigations. Everything came normal. So that will set out that there is nothing organic. Most likely it is somatic symptom disorder. There is no specific treatment for this because you can't give a medication for the patient to stop feeling this. So we say that patient should have a single identified physician as the primary caretaker, because if they go to multiple physicians, they will order multiple investigation and every time the result will be same. Patient should be seen during a regularly scheduled briefly monthly visit. So best idea is that every month patient should come and talk to the doctor. Sometimes you can send them to a psychologist for some psychotherapy and that's all that you can do. But you can't give them any medication. Okay, so that's somatic symptom disorder. Moving on to conversion disorder. Okay, so conversion disorder is a bit different than somatic symptom disorder. So what happens in conversion disorder is that it's a disorder in which individual experience one or more neurological symptoms that cannot be explained by any medical or neurological disorder. So somatic symptom disorder patient will have symptom related to multiple organs. But conversion disorder patient, they are also under a lot of stress, but their symptom is mainly related to some neurological problem. So patient will have one or more neurological symptom, but you can't explain the symptom by any medical or neurological disorder. It is also common in young women, and you can see one or two neurological symptom must have psychological factors. So there will be some kind of stress going on. Mutism, blindness, paralysis are most common. They can also complain abnormal sensation, abnormal movement, weakness, paralysis, pseudo seizures, and all of this. So what happens in this conversion disorder, like you can see from this one, a recently married woman presents to the ED unable to move her lower extremities. A full workup is done, no abnormalities found. So patient saying that she can't move her lower extremities. But let's say you have done everything, nothing come back positive. When further questioned, she reports being beaten by her husband that morning. Okay, so you can see from here that patient actually was beaten in the morning by her husband, and that might be the psychological stress which brought this symptom that she is having now. Okay, so conversion disorder is easy to diagnose because there will be some psychological factor, and in response to that, patient might have some kind of neurological symptom, like patient might not be able to walk or patient might not be able to talk. But if you do investigation, nothing will come positive. Then you can say that this is most likely conversion. There is a thing in here called La-Bella indifference. What is La-Bella indifference? It is commonly found in conversion disorder patient where patient seems unconcerned about the impairment that they are having. So If a patient who can't talk suddenly or who can't walk suddenly, they will be very concerned about it. But this kind of patient will not be concerned about this. They will be more concerned about their psychological stress. Okay? So that's one of the important thing that will give you the diagnosis. So what can you do for it? You can't give any medication. So for this patient also, you can send them to a psychologist, find out what's causing the stress, and gradually counsel the patient, and at some point they will get better. So labella indifference means that patient is indifferent or patient is not concerned about the neurological impairment that they are having. They are more concerned about their psychological stress. Yes, so in conversion disorder, only CNS symptoms will be there. That means only neurological symptoms will be there. So the common neurological symptoms are this: mutism, blindness, paralysis, weakness, sensation problems. So all the neurological symptoms will be there. No, it's not like that. Patient is not faking anything. It is not something that patient is producing. When our mind is a very mysterious thing. So sometimes as a response to the stress, it can work in a mysterious way that actually patient is feeling everything like a patient. So patient will not be able to move it. Okay? So they will have the actual weakness. So it's not that patient is producing this symptom. Okay? So their mind is doing it. If a patient produce symptom, there is certain other condition, like then we call it malingering or factitious disorder. So that is different thing. So this patient is actually feeling the symptom. That means she is actually unable to move her lower extremities. Okay, but if someone is unable to move lower extremities, then something is wrong in their brain. So if you do a CT or MRI, nothing coming up, that's the time you would think, oh no, so this is not like that. Then you go and ask about the psychological stress, you will find something going on. And Dr. Shuha, you have to read depression, bipolar, schizophrenia from UWorld. Yes, everything that we discuss in the class. Moving on to the next topic, illness anxiety disorder or hypochondriasis. So what is illness anxiety disorder? It is a disorder where a patient believes that he or she has a specific disease. Despite constant reassurance, patient's belief remain the same, and the symptom lasts for more than 6 months. So what happens in this hypochondriasis is that patient believes that they have got a specific disease. Like a patient thinks that they have got, let's say they have got a colon cancer. But you have done everything. You have done a colonoscopy, you have done abdominal CT, everything, but nothing is there. So despite constant reassurance, patients still believe that they have got a colon cancer. And it is definitely affecting their day-to-day life, lasting more than 6 months. Then you can say it is illness, anxiety disorder, or hypochondriasis. So it is something where patient is preoccupied with a specific disease. Preoccupation persists despite constant reassurance, but the belief is not delusional. It means that it is not like it can't happen. Like anyone can have a colon cancer. So it is not a bizarre delusion. That is like in illness anxiety disorder, patient will not believe that they have got like they're alien or they have some special power. So they will not believe something like that, which is delusional, but they will believe something which can happen. Okay. So what will you do? Psychotherapy. So some psychological counseling will be needed in this case. Otherwise, there is no medication which can help. Okay, so you can read this one. A 22-year-old woman presents to the doctor convinced that she has a brain tumor. She reports frequent headache that are not alleviated with aspirin. She has been to numerous physicians. All have told her there is nothing wrong. She expects that you can help her because she knows that there is something wrong and you can adequately treat her condition. So the same thing. So despite multiple doctors saying nothing wrong, she believes that she has got a brain tumor. So this is Med Bullets. This link is a good link to go through some of the other example of somatic symptom related disorder. So in here you will see like little bit more discussion about somatic symptom disorder, illness anxiety disorder, and conversion disorder. So please go through that. So illness anxiety disorder is now, previously it was called hypochondriasis. Moving on to BDD, body dysmorphic disorder. So body dysmorphic disorder is very, very important for the exam. It is a disorder characterized by the belief that some part of the body is abnormal, defective, or misshapen. It is also common in women, typically the young women. So what happens in this BDD is that patient believes that certain part of their body is defective. And because of the defective part, everything is wrong in their life. And patient constantly check the mirror to check that defective part of her body. And she consumes most of her time just by checking the mirror. She stops going outside because she believes that everyone is looking at that defective part or talking about that defective part. So socially withdrawn believes that a part of the body is defective and definitely affects their life significantly. That's the time you would call it as BDD. Okay. So a mother of a 20-year-old man presents to your office in tears. She insists that you come to her house and see her son, who has been homebound for several years. Her son refuses to leave the house because he believes he is ugly and people will laugh at him. So, mother of a 20-year-old coming to your office in tears, she insists that you come to her house and see her son because he is homebound. Her son refused to leave the house because he believes he is ugly and people will laugh. He feels deformed and refuses to let others see him. When you arrive at the house, you find an attractive young man with no deformities. So that's what is BDD. Okay, so when a person believes either a specific part or the whole part of the body is defective or misshapen. This kind of condition can be associated with depression, anxiety disorder. Family history of depression and OCD can be common. So we see in here most common concern involves some facial flaws. Constant mirror checking is common. Attempt to hide the deformity, so that's why they become housebound. Avoid social situation, and definitely it impair their level of functioning. So no medication usually, but you can start them with psychotherapy like a cognitive behavioral therapy, which we call CBT, and that usually will help. Sometimes if it is really bad, you can try some antidepressants such as SSRI or tricyclic antidepressant. Okay, but normally it is, first of all, you will send them to a psychologist for some counseling. So who is not able to hear the late lecture? So let me just write something. So first of all, just give me 1 second. Okay, I don't think he's here anymore. So cognitive behavioral therapy, it's a psychological treatment, and it is the commonest form of psychological counseling that psychologists do. So in CBT, what they do is they listen to the patient, they find out what actually bothering them. That means they find out their negative thought, and then they try to counsel them to change that negative thought into something positive. Okay, so that's what we call as CBT, or cognitive behavioral therapy. And most of the psychotherapy there is first started with CBT. So after body dysmorphic disorder, we have got factitious disorder. So what is factitious disorder? So factitious disorder is something where a patient produces symptom for some gain. So it is a disorder characterized by the conscious production of sign and symptom of both medical and mental disorder. So what is the primary gain? Why they want to be sick, or why they are producing the symptom is because that they assume the sick role, and eventually they want to be hospitalized. It means that they want to get some sympathy or care from someone they want. So the main purpose is to assume sick role and not get hospitalized. But if you deny that you don't want to hospitalize them, then they become very angry. Sometimes they can accuse doctors and threaten litigation. And they can become very angry if you confront them and you say that there is nothing wrong. Okay? There are two conditions or two type of factitious disorder. That one, patient can produce symptoms on themselves, or they can produce symptoms on others. Commonly, it can be like parents producing symptoms on their children. So that if children gets hospitalized, they will also get, obviously they will be also hospitalized, right? Or they will be in hospital as well. So sometimes the factitious disorder can be imposed on self, or sometimes it can be imposed on others. Okay? There is a name for this. Do you know anything like what is this imposed on other? There is a very important, like very common name, but difficult name. So this is called mancoition by proxy. So when someone produces symptoms on others, it is called mancoition by proxy. And when it is on themselves, that's mancoition by, I think they are called mancoition by self. Okay. But this is what sometimes they give you the scenario and they ask you this, like, what is the diagnosis? Like if you read this question, you will understand what I'm talking about. A 2-year-old girl was hospitalized after her mother complained that the girl had multiple episodes of apnea in the middle of night. The mother was given an apnea monitor to take home. When she returned, there were numerous episodes on the monitor. While in the hospital, the girl had no episodes of apnea. However, shortly after her mother's visit, there were numerous episodes on the monitor. So you understand, so it is what we call as mancoition by proxy. So in this case, you can't do anything. So this is a difficult situation where you can't confront the patient. You can't do anything. Even sending them to a psychologist usually will not work. Okay. So it is just how you manage the situation. That's it. You can't cure it. You can't manage. You can't do anything about it. So that's factitious disorder where a person produces symptom consciously for some gain, and the gain is not any monetary gain or any other gain. The main gain is that they just want to be hospitalized and they assume sick role. Mancoition by self, that if you say that you are sick but you're actually not sick, so you are just producing symptom on yourself. Malingering. A 40-year-old homeless man presents to the hospital on a cold night, complaining of auditory hallucination, telling him to kill himself. When asked about past psychiatric history, he is unable to give any detailed information. He seems concerned about being admitted immediately, refuse all medication when offered. So this is very common scenario. So homeless man in a cold night, their main purpose is they want to just stay in the hospital. So it is characterized by conscious production of sign and symptom for an obvious gain. The gain can be money, can be that they don't want to go to work, free bed, so something like that. So the main gain is either it's a monetary gain or maybe shelter. So some kind of gain is there, but they don't want to take any medications. So they will refuse everything, but all they want is to admit. Okay. So most express some subjective symptom, tends to complain a lot and exaggerate their effect, preoccupied more with the reward than the alleviation of the symptom. So they don't care about giving medication or taking medication. They're more concerned about the gain. It is common in men, especially men who is in prison, factories, military, etc. So it is also a conscious production of sign and symptom, but it is not that patient wants to be sick or patient doesn't assume sick role. There is another gain out of it. Okay. But factitious disorder, except being admitted and being sick, there is no other gain. And again, there is no treatment for malingering. So Dr. Mitra and Dr. Jarin, Mancussion by self means that when a patient produces symptoms on themselves, like they say that they are sick or they are having some symptoms. Mancussion by proxy means they are not producing symptom on themselves but on someone else, like mother producing symptom on their child. And Dr. Noda, you have got your answer. What is the difference between factitious and malingering? Moving on to generalized anxiety disorder. So generalized anxiety disorder, it's someone who are anxious about everything. So excessive, poorly controlled anxiety about most of the trivial or small things that goes on their life. And this excessive anxiety or worriness will continue for more than 6 months. So this is the commonest presentation of mental symptoms or psychological symptoms in general practice in Australia. So this is one of the questions that came in exam. So what is the most common psychiatric presentation in Australia? That's generalized anxiety disorder. So it is also common in female, but the main thing that you should remember that it is a patient who has excessive anxiety and worry about various life circumstances, not related to anything specific. So they are worried about everything. Now, the diagnostic criteria is 3 out of these symptoms. So patient along with excessively worriness or anxiety, they will be very restless, on edge, keyed up, easily fatigued, difficulty concentration or mind going blank, irritability, muscle tension. So some of these will be there in the exam question. Like they can say that patient is always on the edge, or patient says mind is going blank. So some of these clues will be there, and if you know it, you can easily pick it up. Because it causes a lot of symptoms in a patient. So patient with generalized anxiety disorder, they can have psychological and physical symptoms. As part of psychological, they can have like irritability, sleep disturbance, impatience, sensitive to noise, Physical symptoms, muscle aches and pain, twitching, shaky, restless, dry mouth. Okay, so any of this can be there. So what will you do for this patient? For generalized anxiety disorder, first of all, you will send the patient to a psychologist, because psychological therapy is the first line treatment for most of the anxiety disorder. And most of the time you will send them for CBT. So do not rush into giving them medication, because let's say this generalized anxiety disorder patient can have sleeping problem. Will you just give them some benzodiazepine because they can't sleep? No. Very rarely in the exam you would give benzodiazepine to a patient. Just because patient having sleeping difficulty doesn't mean that you are going to give the patient some sleeping pill. That's not the way to treat the patient. Okay. So first send the patient to a psychologist, and that is the first line. If psychological counseling doesn't work, then you can try an antidepressant. And the first line antidepressant is SSRI. If SSRI is not working, then SNRI such as venlafaxine, desvenlafaxine, or duloxetine can be tried. It can take at least 3 months for this antidepressant to work. So let's say you started antidepressant, and after a month, patient saying it doesn't work. What will you say? You will say that it can take 3 months for this medication to work. So let's continue for a few more months and let's go from there. Okay? Benzodiazepine have a limited role in anxiety disorder. If used, they should be reserved for people who haven't responded to at least 2 treatments, such as psychological therapy and antidepressant, used only for a short term. So you have to stop it within 6 weeks. So remember, benzodiazepine for this generalized anxiety disorder, you will only use it if you have tried psychological treatment that failed, you have tried antidepressant that failed, then just for very short term, you can use some benzodiazepine. That's it. Okay? Why we don't like benzodiazepine? It's because that it has addictive nature, so you can't just give it to them for a long time. And there is also another thing, beta blocker like propranolol. It is only needed in some patients who has like a specific social anxiety disorder. Like whenever they go for a public speaking, they get quite anxious and panicky. So 30 minutes before a public speaking, they can take propranolol, and that can help with their symptom. So propranolol only given if a patient have a specific social anxiety disorder. Okay, not in every other cases. And if we need to use a medication for anxiety disorder, definitely it is not our first line option. Our first line option is psychological treatment, which is CBT. If CBT doesn't work, and then we try some medication. So you can see for most of the anxiety disorder, if we are going to start a medication, SSRI is our choice. Okay. And we discussed what are these SSRI in our previous class in psychiatry class 1. So please make sure you go through them. Why benzodiazepine for short period? Because of its addictive nature. It can cause addiction. And still confused between factitious and malingering. So it's very easy in that way if you understand the basic. So factitious means they produce symptom just because they want to be admitted in the hospital, and they will take all the medications that you are going to give to them. They're happy with that because all they want is to say, or is for you to say that they are sick and they can be admitted in the hospital. They don't have any other gain. They are not getting admitted because they don't want to go to work. They are not getting admitted because they will get some shelter. All they want is for you to say that they are sick and they can be admitted. Then they will take all the medication that you give. On the contrary, malingering patient, they also produce symptom, but there is some specific gain. The specific gain is not assuming a sick role and getting hospitalized or getting all the medication. The gain is something like maybe a prisoner doesn't like the prison and wants to be hospitalized. Maybe a military worker doesn't like to go for a shift today, so he's just producing some symptom. Okay, maybe a factory worker, he doesn't want to go to the work today and he's just producing some symptoms. So there is some gain. It's not like they want medication. If you offer them like, well, let's get admitted and let's start this medication, they will not start the medication. All they want is to be admitted, or all they want is to produce symptom for some other gain. Okay, not just to be admitted or not just to be sick. Making sense for everyone? Okay, panic attack. So panic attack is a severe anxiety attack where a brief period of intense fear or discomfort can happen. So you all know about panic attack. So it is the severe form of a anxiety disorder where patient gets very sudden onset of intense anxiety or discomfort. And in that time, patient can get short of breath. They can feel someone is choking them, dizziness, lightheadedness, palpitation, trembling, shaking. They can have a feeling of choking, nausea. They can have numbness, tingling, flushes, chest pain. Fear of dying is very common. Fear of going crazy. Okay. So this is not like a persistent symptom. Maybe for 10 minutes, patient will have this symptom and then they will get better. And they can get it multiple times. Sometimes this panic attack can be confused with some organic disorder, like hyperthyroidism patient can have similar symptom, hypoglycemia, pheochromocytoma. This can mimic the symptoms panic disorder patient having. So you'll always rule this out first. Now, a single panic attack doesn't mean anything. But when a patient gets recurrent panic attack, okay, so a patient who gets a recurrent panic attack that are followed by at least a month of worrying about future attack and consequences of them. So once a patient starts to get multiple panic attack, they starts to get worried. And what they do is that they keep on thinking about their next attack and they stop going outside, they stop going to the crowded places. This recurrent panic attack with worrying about the next attack is what we call as panic disorder. When a panic disorder patient, because they feel that if they get the panic attack in a crowded place, they will get ashamed or embarrassed. When a panic disorder patient stop going outside or stop going into the crowded place, there is a name for it, is what we call as agoraphobia. So first, panic attack. So single panic attack, nothing. Multiple panic attack and patient keep worrying about them, that's panic disorder. Panic disorder patient stop going into the crowded place, that's agoraphobia. Okay. So what we'll have to do for this kind of patient, because panic attack happens very short period. So when it happens, you might not even see the patient. So all you can do is reassurance, explanation, and support. But if you see a patient while that patient having a panic attack, then you will ask the patient to take some deep breath. So mainly deep breathing is what they should do during the panic attack. Okay. And then when someone's come to you with multiple panic attack, first thing that you would do is to send them to a psychologist for cognitive behavioral therapy. And usually because panic attack happens for just a very short period of time, pharmacological treatment is not indicated. But sometimes if you can't get help from CBT alone, then you can try some antidepressant in this patient. But main treatment for panic attack is CBT. Next, phobic disorder. So all of you know about phobia. There are lots of phobia. So patient who has phobia to go into the crowded place called agoraphobia. Patient who has phobia to go into social places, social anxiety disorder or social phobia. And there are some specific phobia like height phobia, water phobia, right? Insect phobia, lots of phobia is there. So those are specific phobias. In phobia, patient avoid the objects or situation they are afraid. And if they are going to meet those situations, they become quite anxious. So this is from Kaplan step to second. So you can read the panic disorder from here, nothing specific. So let's have a look in here. There are some specific phobias which we talked about. A specific phobia can be animal related, can be injury situation related. That's fine. What is this social anxiety disorder? Social anxiety disorder, there are generalized social anxiety disorder and there are specific social anxiety disorder. Generalized means whatever it is, whenever patient go for a social meeting, they get anxious. A specific social anxiety disorder means like there is some certain period like public speaking or maybe in front of like in the stage. So in some certain social situation, they get the anxiety. So that's called a specific social anxiety disorder. Okay. Now we will go into a little bit more detail later on, but for phobia, the main treatment is cognitive behavioral therapy, but there is a specific CBT that we use for this patient. It is called systemic desensitization and assertiveness training. So what is systemic desensitization and assertiveness training? For patients who have this kind of phobia, you gradually expose them to their phobia and then make sure at certain time they would not even feel that they had a phobia against it. So it is called gradually desensitizing the patient. Okay? Like someone who is afraid of dog. Will you just take the patient to a dog in the first time and ask them to pet the dog? No, you would not do that because they can have an intense panic attack. So what will you do? You might just start first, maybe just talk about dog and talk about some of the stories and how good that they can be, and then you can maybe show a photo of a dog, see how the patient is like taking it, and then maybe show the patient like a dog from miles and miles. Maybe just show them from distance that this is a dog. Have a look how funny they are or how much playful they are. Okay, and then gradually you will take the patient in front of the dog or puppy, and at some point he or she might be able to pet or maybe take care of the puppy. So this is called gradually desensitizing someone to a particular phobia. Okay. And if that doesn't work, so if CBT doesn't work, then there are pharmacotherapy like SSRI that can be used sometimes, not always. So phobic disorders, we know about specific phobia, we know about social anxiety disorder, we know about agoraphobia. Okay, so social anxiety disorder is experienced in anxiety-provoking social situation in which person feels subject to critical public scrutiny. It can be generalized. So when a person has anxiety in numerous social situations, or non-generalized, where patients usually have one or two areas when they get the anxiety. The treatment for the two is different. That's why it is important to know that is it a generalized social phobia or is it a specific social phobia? The basis of treatment for all phobias is psychotherapy that involves behavioral therapy, which is graduated exposure, and cognitive therapy. So we call it exposure and response prevention. A lot of name is there. So there is like systemic desensitization and assertiveness training. That's one name. Another name is exposure and response prevention therapy. Okay. So that's all about the social anxiety and everything. Now, it's very important to understand that if a patient has got a specific social anxiety disorder, so a specific social phobia, you can give them propranolol or beta blocker just half an hour before their specific social situation. So for a specific social anxiety disorder, the treatment is propranolol apart from the CBT. And for generalized, initially CBT. If CBT doesn't work, then SSRI. Okay. All good, everyone. You guys are so far all good. Any questions? So in here, I have given some of the link. So you can see panic attack, panic disorder link, phobic disorder link, and OCD or obsessive compulsive disorder link. So go through this link. It will give you a bit of more idea. Going into obsessive compulsive disorder or OCD, very important for exam. So there are two things. One is obsession and another is compulsion. So obsessions are recurrent, persistent thoughts which patient cannot resist. Compulsion are intentional behavior or ritual that patient needs to do in response to that obsessional thought. So let me explain what I say. Obsessions are a recurrent thought a patient has constantly in their head that if they don't do it, something bad will happen. Now, to alleviate that anxiety, patient will do that particular thing as a ritual. Like someone thinks if they don't wash their hand multiple times in a day, they will catch serious infection and they can die. So that's their obsessional thought. And they can't stop that thought. They know that this is unreal. So they are not a schizophrenic patient or delusional patient that they believe that this is going to happen. They know that this is unrealistic and this is not right. But they can't resist the thought. Now, because they can't resist the thought, to alleviate this anxiety, to alleviate this obsessional thought, they have to wash their hand multiple times, sometimes even 100 times in a day. That's compulsion. Okay? So obsessions are those thoughts which are recurrent, persistent. Patient usually can't resist them. And the compulsion are those behavior to alleviate their obsessional thought. Now, this patient has insight. That means they know that they are having some problem and then they will come to you for help. Whereas schizophrenia or mania patient, they don't believe that there is something wrong because they don't have insight. So what is the management of OCD? So OCD management is a combination of psychological treatment and medical treatment. So you will go for CBT. The CBT we do is cognitive behavioral therapy for the obsessional thought, exposure and response prevention for the compulsive behavior. So first you will give psychological counseling for the thoughts, and then you will go for exposure and response prevention for the compulsive behavior. If this doesn't work, then your treatment will be antidepressant, which is SSRI. So you can see some of the obsessional thought can be like commonly hand washing, organizing, checking, counting, praying. So lots of OCD related symptoms are there. Now OCD sometimes can have association with like depression. It can also have association with sexual abuse, especially childhood sexual abuse. Okay. So that's OCD. No, it's kind of like it's trying to say that patient wants to resist them, but they can't resist the thought. So because they know that this is wrong, they initially try to resist the thought, but if they resist it, the thought become worse. So at some point, they no longer able to resist the thought. They have to do those things, do the compulsion to alleviate this thought. Okay. And if we are going to give some treatment for panic disorder, Mitra, it will be SSRI. Moving on to acute stress disorder, and then we have got post-traumatic stress disorder, PTSD. So acute stress disorder, it is a combination of some abnormal anxiety-related symptom which last at least 3 days, but less than a month. And it occurred within 4 weeks of a significantly traumatic event. So we say that acute stress disorder and PTSD, which is post-traumatic stress disorder, the symptoms are same. It is the duration which differentiate between this. So in both of the condition, patient will suffer from a very bad traumatic event, okay, which human mind is not made to process those events. Like let's say if someone has seen that everyone in the ship was drawn except maybe few of them are alive, or there was a bombing event, most of the people are dead but some of them survive, or you have seen that one of the bus just killed a person on the road. So these are significantly traumatic events which no one can process, right? So in response to those significant traumatic events, patient can have some symptoms which we say patient can have flashback of those events, so recurrent flashback. Second, patient can have bad nightmares, so they will have sleeping problem because of that. They will have avoidance behavior, and avoidance behavior means they will avoid anything related to that particular event. Some maybe newspaper, news, anything related to that particular area or particular event, they will just avoid it. So they will even avoid going to that place. So that's avoidance behavior. 4, exaggerated response, which means that they will get they will get startled and agitated and very angry. So exaggerated startle response, or we call it hypervigilance. So they will be very alert all the time. So when someone has got these symptoms and they also have that like history of those traumatic events, then you can call it as acute stress disorder or PTSD. So acute stress disorder means that symptom will not last more than a month, whereas PTSD symptom will last more than a month. Okay. So apart from these 4 main symptoms, patient can have other symptoms like sense of numbing. They can have amnesia of the event. That means they can totally forget about that event. Intrusive memory or dreams of the event. Then avoidance, sleep disturbance, hypervigilance, exaggerated startle response, agitation, everything. For this patient, Pharmacological treatment is rarely indicated. You can start with some psychological counseling like debriefing and counseling. That's usually the treatment. What about PTSD? PTSD also we divide. So you can see it refers to a similar symptom, but it persists for more than 1 month after exposure. We also divide PTSD as acute, chronic, and delayed onset. So acute means if symptoms less than 3 months, chronic more than 3 months, and delayed onset means patient had a traumatic experience 6 months before, and now the patient having the PTSD symptom. So you can see some of the symptoms in here which we discussed. Now, treating a PTSD patient is very, very difficult. So for this patient, you will need to send them to a psychologist, and you might also need to try pharmacological treatment. So you will send them to a psychologist for a focused psychological intervention therapy. So that's the treatment, focused psychological intervention therapy. There are lots of other treatment for which I would like you guys to go through RACGP guideline. RACGP has got a bit of discussion about PTSD and their management. So make sure you read from it. But one of the psychological treatment that we offer is focused psychological intervention therapy. What is the pharmacological treatment? SSRI has limited evidence, but that is what usually you will try. So you will try SSRI. Sometimes it can take a longer period of time to have any effect. So patient who needs SSRI for this problem, they needs to be on this medication for at least 12 months. Okay, so that's the treatment, focused psychological intervention therapy. Now this is from Kaplan step to CK. So they also talked about same thing. So severe anxiety symptom following a life-threatening event that caused feelings of fear, helplessness, or horror. Like PTSD will not happen just because someone has a breakup with their boyfriend or girlfriend. It's not a PTSD. PTSD has to have something really distressing, something very traumatic. Then you can think of PTSD. We talked about the key symptoms. So re-experiencing the event, which is flashback nightmare, avoidance behavior, and increased arousal. They also have this survivor guilt, which means that they feel like they are guilty because why they live, why not they are dead. So they have a survivor guilt as well. Okay, so that's PTSD. Now I would like to take a 10-minute break before we proceed further. Any questions up to this? For that question, Dr. Nodua, it is not agoraphobia, right? Patient is not having any panic attack, so it can be a stress disorder. Doesn't matter, acute, chronic, delayed PTSD, this doesn't come in exam. So don't get concerned about it. Just remember ASD means less than month symptom, more than a month PTSD. Delayed PTSD means that 6 months after the traumatic event, patient started to get the symptom. So that's why it is called delayed onset. All right, 10 All right, everyone, let's start the session again. So we finished up to PTSD. Now we are moving on to adjustment disorder with anxious mode. Now, adjustment disorder is very important for your exam because it commonly get confused with depression. So let's discuss how we can differentiate adjustment disorder from depression. Many of the symptoms will go with depression, but there are few things that will help you to diagnose adjustment disorder. So it is reserved for patients who present with anxiety symptoms within 3 months of response to an identifiable psychological stress. So someone who had a breakup with their boyfriend or girlfriend, within 3 months of that stressful situation, patient started to produce certain anxiety symptoms. So sad, emotional, crying, sleep difficulties. So all of those that can be diagnosed as adjustment disorder. So this is kind of like a identifiable stressor, and the stressor is not significant like PTSD, but there is a stress, and in response to that, within 3 months, patient will have some excessive anxiety symptom. So we call it like symptoms are excess of the normal expected reaction to the stressor and persist less than 6 months following the removal of the stressor. So once the stressor is done, and the symptom will not last for more than 6 months. The basic treatment is non-pharmacological, which is counseling. So you can see the DSM-5 criteria. So emotional or behavioral symptom in response to an identifiable stressor occurring within 3 months of the onset. Marked distress, which is out of proportion of the intensity of the stressor, causing significant impairment in social personal life. Now, this is very important. This disturbance or symptom must not meet the criteria for another mental disorder. And symptoms do not persist for more than 6 months. Now, there are questions where they give you a stress and then they give you symptoms of depression. And if you know the M-Psych-CAPS criteria to diagnose major depressive disorder, there are questions where there is a stressor, but patient fulfills the criteria to be diagnosed as MDD or major depressive disorder. So just because there is a stressor and patient having anxiety symptom doesn't necessarily mean that it can be adjustment disorder. You can only diagnose someone as adjustment disorder when their symptom does not meet criteria for any other mental disorder. Okay, so let's say that if your patient's symptom meet the criteria for depression, then the diagnosis cannot be adjustment disorder. Diagnosis will be major depressive disorder. Does it make sense for everyone? Because that's what confuses people a lot in the exam. They think that because there is a stress, patient having symptoms of anxiety, even though that patient fulfill the criteria of MDD, they don't diagnose them as MDD. They diagnose them as adjustment disorder, which is wrong. So it means that you can only diagnose someone as adjustment disorder if they don't fulfill criteria for any other mental disorder. Okay? Like let's say in the patients that, let's say a patient, 28-year-old woman, had a, or you can say has been cheated by her boyfriend, and in reaction to that, patient started to become very emotional, sad and gloomy. So they are having, let's say, insomnia, loss of appetite. They also have loss of interest to do anything. They have loss of concentration, loss of energy. So that means this patient is fulfilling the criteria of major depressive disorder, right? So Now, I can't discuss the depression again because we have already done it. So if you guys haven't done it, then you should make sure you go through that last class. But if someone has got major depressive disorder criteria, then the diagnosis will be MDD, not adjustment disorder. Just because she had a stress and in relationship to that, patient started to get this symptom, you can't just diagnose them as adjustment disorder. Okay? Make sense, guys? What is acute stress disorder? Acute stress disorder means a significantly traumatic event. Is breaking up with a boyfriend significantly traumatic event? For some patients it might be, but actually it is not that significant, right? So for acute stress disorder, it has to be a significantly traumatic. Okay? But adjustment disorder is like some life stress. Maybe losing someone, maybe it could be breakup, divorce, separation, something like that. Lifestyle stress. Okay. So that's all about this adjustment disorder. Moving on to another topic, which is dissociative disorder. Now, this is a tricky discussion and it is a bit of complex, but we'll try to make it as easy as possible. It is the same thing, Dr. Mitra. Adjustment disorder with depressed mood is the adjustment disorder. So it is the same thing. So because this patient usually has features of depression, like lots of features or lots of symptoms goes with depression, but you can't get the full criteria of MDD in an adjustment disorder patient. So adjustment disorder with anxious mode, adjustment disorder with depressed mode, these are more or less same thing. The main criteria is that that patient does not fulfill the criteria of MDD. So dissociative disorder, first of all, dissociative amnesia. So what is dissociative amnesia? Significant episodes in which the individual is unable to recall important and often emotionally charged memories. So dissociative amnesia means that sometimes patient can forget a very important memory of their life. And those memories tends to be like emotionally stressful memory. So that's dissociative amnesia. What is dissociative amnesia with fugue? It means that it involves purposeful travel or bewildered wandering. So in dissociative amnesia with fugue, it can be like a farmer, or let's say someone, let's just say like 20-year-old was in a shopping mall in Sydney. And then next day, she found herself in Melbourne in another shopping mall. How she came from Sydney to Melbourne, she can't remember. Okay. Now, that is what we call as dissociative amnesia with fugue. So patient definitely traveled from Sydney to Melbourne, but she can't remember how, when, and why she has done it. Okay. So dissociative amnesia is just like unable to recall some important memories, whereas dissociative amnesia with fugue involves a purposeful traveling to somewhere and patient can't remember that. There is always a psychological stress underneath all of this, so you'll need to find that out. The amnesia may suddenly or gradually remit, particularly when the traumatic circumstance resolves. So this amnesia is not permanent. So in this situation, first of all, you'll need to rule out some of the main thing, like if someone has got amnesia, you want to rule out head trauma, seizure, stroke, substance abuse. So all of this you will need to rule out. And if you rule that out, then the only treatment is psychological treatment. So psychotherapy. Next, dissociative identity disorder. This is also known as multiple personality disorder. Presence of multiple distinct personalities that recurrently control the individual's behavior. So multiple personality disorder means that patient will have multiple personality, and at some point one personality will be the main personality, and then at other time other personality will be the main personality. So patient lives 2 or 3 lives at a time with different personality, but they can't remember the previous personality. Okay, so let's say a single person, they are living 2 or 3 personality. At some point this personality is the main one, at some point he is the main one, at some point he is the main one, but none of them remembers the other personality. Okay, childhood sexual abuse sometimes could be a risk factor. So sometimes let's say that a priest who on the day, or who in the day preach religions to others, okay, do all the good things, and then at night or at some other part of the day he robs from the shop or he steals from others, but none of them can remember each other. So that means that the same person is living 2 different kind of personality, and that is what we call as dissociative identity disorder. Okay, so the treatment is again psychotherapy to find out what was the psychologically traumatic event that patient had and try to resolve that, because deep down patient had something really traumatic psychologically, and you need to find that out, resolve that, and then the patient will get better. Okay, so we discussed about dissociative amnesia, where patient forgets about their important memories. Dissociative amnesia with fear, which is like traveling from one place to other but can't remember. Then multiple personality disorder, okay, or we say dissociative identity disorder, when a person has multiple personality and at some point one takes hold, others doesn't, and they don't know each other. Then there is depersonalization and derealization disorder. Now this is tricky. Depersonalization means that, so this 2 condition, it means that a patient has a feeling of being detached from one's mental process or one's body. So depersonalization is mainly that. In depersonalization, patient believes that their body is detached from their mind, or they get this out of body experience. Okay, so when someone feels that their body is not part of them, it is detached from their mind or soul, that's what we call as depersonalization. There is always some psychological stress behind it. So what is derealization? Derealization means patient feels that they are detached from their surrounding. That means they can't remember their environment. So when someone believes that their body is different or their body is detached from their mind or soul, that's depersonalization. And derealization is when a patient believes their surrounding is detached from their body. Okay, So it is a feeling of being detached from physical surroundings. Common events are jamais vu and déjà vu. Jamais vu means that a sense of familiar things became strange. That means a patient who is born and raised in a certain place suddenly feels that they don't know this place. That's jamais vu. So familiar things becoming unfamiliar. Exactly the opposite is déjà vu. Patient never came to a place, but when they came, they feel that they were here for a long, long time. So unfamiliar thing becoming familiar. That's déjà vu. Okay, so jamais vu and déjà vu is a bit of a part of derealization disorder. So it's very easy if you think in that way. If someone believes that their body is detached from their mind, that's depersonalization. If they feel that they are detached from their physical surrounding, that's derealization. Okay. If you go to Med Bullets and go through this dissociative disorder, it will give you a bit of more discussion about these three things. So let's see. A 39-year-old priest is surprised when a woman states that she saw him at a casino several days ago. He denies this accusation and truly has no memory of the event. So what is this? A priest playing casino, but he can't remember that. So that is what we call as dissociative identity disorder. Okay. A 29-year-old woman presents stating that several times last month she felt as if she was outside of her body. She struggled to describe the experience, and she says that it's like watching a movie of herself. So what is this? That's deep personalization, out of body experience. In this situation, the best initial step is the neurological testing to rule out any other neurological condition. And then once we rule out, we go for psychotherapy. A 21-year-old woman is reported missing by her parents in New York. Years later, it is discovered that she is living in Florida. She has no recollection of her previous life in New York. So what is this? Most likely she came from New York to Florida and she can't remember it. So that's dissociative fugue. Okay? Is it all right for all of you now? You guys now understand these three things? And jamais vu, Dr. Faria, it means that when a familiar things become unfamiliar. That was Med Bullets. Okay, moving on to personality disorders. Personality disorders are very important and lots of personality disorder are there. So we divide someone's personality into cluster A, which is withdrawn personality, cluster B, antisocial personality, and then cluster C, which is dependent personality. So let's talk about it. Cluster A, first of all, paranoid personality disorder. Always remember, personality disorder means that it is how a person is. It just can't happen within a week or month. Patient was like this throughout their life, right? So paranoid personality disorder means they are distrustful and suspicious of everything. So individual who has paranoid personality disorder, they are mistrustful, suspicious of motivations and actions of others, and they are very isolated because of that. So if let's say a 57-year-old man living in a condominium constantly accuses his neighbors of plotting to avoid payment of their share of maintenance. So paranoid means always suspicious. So they believe that someone is trying to harm them, someone is spying on them, or maybe someone is constantly plotting against them. Okay. He writes angry letters to other owners, has initiated several lawsuits. He lives alone and does not socialize. Okay. Next, schizoid personality disorder. So paranoid means distrustful and suspicious. What about this schizoid? Schizoid are very detached and restricted emotionality. So they are very emotionally distant. They are not interested in others. They don't care about if someone is praising them or criticizing them. And they like to be alone and isolated. So 24-year-old man lives alone, works nights as a security guard. He ignores invitation from co-workers to socialize and has no outside interest. So very easy to diagnose that when someone has no interest in others, only wants to live alone, distant, isolated, and emotionally very cold and distant, that's when we will call them as schizoid personality disorder. Okay. Next, schizotypal. The 57-year-old, can it be malingering to avoid paying rent? No. Is he making any symptoms? Malingering has to make a symptom. Okay. And malingering cannot be for lifelong. This is something which is lifelong. Schizotypal. So in a word, schizotypal means they are very odd and eccentric. So individuals are isolated, uncomfortable with others. Unlike schizoid, they have peculiar pattern of thinking. They have odd preoccupation, odd speech, odd dressing. So everything is odd and very easy to differentiate that they feel that they have some special power. They can tell fortune, they can read hands. Okay. So and their dress can be very odd and eccentric as well. Like this one, a 30-year-old man is completely preoccupied with study and brewing of herbal teas. So this schizotypal patient, they have a particular interest to one thing, and they do everything related to that. So they have a particular interest. He associates many peculiar powers with such infusions and says that plants bring him extra luck. He spends all of his time alone, often making solitary walks in the wilderness for days at a time, collecting plants for days. No other abnormal behavior. He believes that songs on the radio are about his life. Now, just because they have this abnormal belief, don't think that this is schizophrenia. Okay? They can have this kind of abnormal belief, but that doesn't make them schizophrenic. Okay? Now, for schizotypal, the best way to remember is that they have this kind of odd preoccupations. So they believe plant brings them luck. Or sometimes one of them feel like they can read the hands of the people or can tell their future. Okay. So those are what we call as schizotypal, and they have particular interest in something. Yes, we can say magical, right? Good. Next is cluster B, histrionic personality disorder. So histrionic personality disorder are common in female, where patient usually they are characterized by colorful, exaggerated behavior. But the main thing is that they use their physical appearance to draw attention to them, sexually seductive, and if they are not center of attention in some situation, they become very uncomfortable there. So it means that this personality disorder, they want everyone to talk about them. They want to be the center of attention. And if they can't, then they will draw the attention by being sexually seductive. A 30-year-old woman presents to the doctor's office dressed in a sexually seductive manner and insists that the doctor comment on her appearance. When the doctor refuses to do so, she becomes upset. Okay, so that's histrionic. Next, borderline personality disorder. Very, very important for exam. Okay, so all these three, borderline, antisocial, narcissistic, this comes in exam. So borderline personality disorder, they are characterized by unstable affect, frequent mood swing, marked impulsivity, unstable relationship, recurrent self-harm or suicide, and inappropriate anger. So borderline personality disorder, this is also common in female. In this condition, patient have some specific sign and symptom. One, that they have frequent mood swing. That's why they have unstable relationships. So multiple broken relationship, broken marriage, and self-harming behavior. Markedly impulsive, like if they become angry, they can just do anything to harm themselves. Remember, they harm themselves, not others. Whereas antisocial, they don't harm themselves, but they harm others. That's the main difference between them. So 20-year-old nurse was recently admitted after reporting auditory hallucination. So sometimes when these borderline patients are stressed, they can become psychotic, which have occurred during the last few days. She reports marriage difficulties, believes her husband is to blame. She has several scars on her wrist. History of substance abuse, which is because they're very impulsive. And they have a defense mechanism called splitting. Splitting is a defense mechanism where they believe everyone is either good or bad. There is nothing average or in the middle. So they will always believe that this person is really bad or really good, not a mix of good and bad. Okay. So that's borderline personality disorder. Next, antisocial personality disorder. Antisocial, as the name says, they have all the criminal things. So patients who does antisocial or criminal acts don't abide by the social rules and harm others, very aggressive, violent, lack of remorse, they are called antisocial. You can't diagnose anyone as antisocial before the age of 18. Remember that. So before the age of 18, you can't diagnose them as antisocial. How about narcissistic? Narcissist, like antisocial is common in men, narcissistic common in men, whereas borderline and histrionic common in female. Narcissistic, they are characterized by sense of self-importance, grandiosity, preoccupied with fantasies of success. Now remember, narcissistic, they are very egotic. They also want to be center of everything, and they feel that they are very special and require excessive admiration. You can't criticize them. They are jealous or envious of others and exploit others for their benefit. Okay? Like this one, a famous actor is outraged when a director questions his acting abilities during rehearsal for a play. The actor responds by walking off the stage and not returning to the stage unless the director apologizes publicly for her behavior. So narcissistic are like this. They are very egotic. grandiose, preoccupied about their success, and they're also like they can't take criticism. Okay, so that's your all the cluster B personality disorders. So to summarize, borderline, broken relationship, mood swings, impulsive, suicidal behavior. The management of borderline personality disorder, there is a psychotherapy that you can do. Is called dialectical behavioral therapy, DBT. What is DBT? DBT is a kind of CBT, but DBT is mainly focused on suicidal behavior. So in this psychological treatment, the psychologists mainly focus on their suicidal behavior, help them to understand that this is not the way to get relief of their anger. Antisocial means like definitely who is aggressive to others, narcissistic who is egotic and exploitative. Cluster C, avoidant personality disorder. Avoidant personality disorder are patients or individuals who have social inhibition, feeling of inadequacy, and very hypersensitive to criticism. So they shy away from work relationship because of fear of rejection that are based on feelings of inadequacy. They feel lonely, substandard, preoccupied with rejection. So avoidant personality disorder and schizoid personality disorder, it looks same, but why they are not same disorder? Because schizoid, they prefer to be away from others. Whereas avoidant, they want to socialize, but they can't because they have this kind of inferior complexity that they feel like they are not adequate enough to socialize with others. So that's why they avoid going to the social places. But actually they want to socialize. Okay. Next, dependent personality disorder. Dependent personality disorder are those person who are quite clingy and submissive. So they have this constant need to be taken care of. They are clingy. They worry unrealistically about abandonment. They also feel inadequate and helpless. So you can see a 26-year-old man is brought into emergency room after sustaining several severe rectal lacerations during a sadistic sexual episode with his partner. The patient is extremely concerned that the police not to be informed because he does not want to upset his partner and cause the partner to leave. So you can understand the dependent personality. They don't want to be abandoned. They feel inadequate and helpless, even though like you kick them out, they will come back. Okay, because they have this submissive behavior always. Next, obsessive compulsive personality disorder. Now, obsessive compulsive personality disorder is not same as OCD. It's different. So what is OCPD? These are the patients who are preoccupied with being perfect. So preoccupied with orderliness, perfectionism, control. They often consumed by the details of everything, lose their sense of overall goals. Very strict, over-conscientious, inflexible. They're very upset with their work, doesn't like to delegate tasks to others. So what happens in these patients is that they are perfect. They wants to keep everything in order, doesn't like any others work, but because they're inflexible, very strict, and they do their work in a very detailed way, they miss the overall goals eventually. So that's OCPD. Like a 37-year-old woman seeks psychotherapy as a result of an impending divorce. She stated that her demands to keep the house spotless, to maintain an extremely detailed and fixed work and recreational schedule, and to observe rigid dietary habit have driven her spouse away. Okay, that's OCPD. This is one of the Med-Bullet guideline about this personality disorder. So you can also go through this link and go through some of the example of this personality disorder. That will also help. Okay. So that's all about our tonight class, guys. Any questions? Difference is OCD patients will have the obsessional thought and then compulsive behavior. OCPD patient doesn't have any obsessional thought or compulsive behavior. All right, so that's it for tonight, guys. So I hope you enjoyed the session. I hope things are not that hard as you thought. It's all about understanding this specific topic because most of these are very new for you. So if you understand them clearly, it can be very easy and interesting. Okay. And definitely, if you missed the first class, make sure you go through them. Okay. All good, everyone. Thank you for being actively participating. We'll see you in the next class. Thanks. Bye.